very excited to have everyone here today. Got a great crowd already, and it'll continue to grow here over the next couple minutes. We have a really tremendous guest today, and I am super excited to hear this discussion and this talk. Dr. Sachin Agarwal is a neurologist at Columbia University and director of the Neurocardiac Comprehensive Care Clinic. And he's really an expert in cardiac arrest survivorship, right? And as such has really helped be a fundamental force within the Heartsite organization, which is really dedicated to help folks who've been impacted by cardiac arrest, either survivors of cardiac arrest, those who've witnessed cardiac arrest, those who are a co-survivor, or who have a loved one who's suffered a cardiac arrest or have lost a loved one. And the resources and the effort that Heartsite has undertaken is really just tremendous. And we're lucky to have a little inside view of this, as Ann Dahl is one of the board members for Heartsite. But just to learn more and share the mission of Heartsite is today's webinar. And we're so excited to welcome you, Dr. Agarwal. Take it away. The floor is yours. Pop those slides up and we'll be rocking and rolling. There they are.
Thank you, Andy. Yeah, you guys can see my slides?
Yeah, they look great.
Okay, perfect. Thank you so much again. Really an honor to present today, and on behalf of the Heartsite team who have done the hard work behind this initiative, and their efforts are, I believe, really helping the closing that gap, the long-standing gap in our understanding and supporting the life after cardiac arrest. Before I begin, I really want to acknowledge our colleague Anne, who recently suffered the heartbreaking loss of her husband Larry, and really extend our heartfelt sympathy to her and her son. And I know many of us are holding them in our thoughts. And in that spirit of support and togetherness, let's turn to the focus of our session, which is supporting survivorship with trusted information. And here's our group. This is the Heartsite core group that initially got together with diverse backgrounds and skills. They represent clinicians, survivors, researchers, co-survivors, grieving families, lay rescuers or lay responders, first responders, the EMS professionals who care for these patients in the beginning, and then also the healthcare professionals that come after. And a lot of them are advocates. And our journey of coming together did not stop here. And recently, we also worked with a lot of the pediatric experts who are working in the field of resuscitation science, and created a module called I'm a Parent for parents whose loved one, whose kids have survived this traumatic event. So I have no industry affiliations. All the work that we're going to discuss today is a product of federal funding from NIH. And it's really a pleasure to be here and discussing work that is not only recognized among the groups with us or elsewhere, but also with the federal agencies. So the premise of our work has always been that a single cardiac arrest, whether it happens at home or in public, it affects far more than just the patient. So there are families, there are lay responders, EMS, healthcare team, they all carry the impact of this life-changing event. And so if you estimate 365,000 out-of-hospital cardiac arrest a year in the United States alone, then you're saying that 2.5 million people face the uncertainty that follows, and looking for the reliable, trusted resources and informational resources to help guide their recovery. So for example, this is the journey of a family member of a cardiac arrest patient. Very early on, there are elevated levels of uncertainty when they are involved either with witnessing or providing CPR, or making that first 911 call. Then comes the uncertain role of a surrogate when they are given a lot of medical decisions to make, including signing consents, understanding whether this is going to be a cooling protocol or not, what are the benefits, and then also like ECMO and where it's going to go, how soon their loved one will wake up, if they will wake up. So a lot of neurological prognostication is baked into this hospital setting where they are going through the motions a lot of uncertainty. And then comes if the patient, if their loved one do survive, then comes the uncertainty as a caregiver without any formal training, understanding and sort of like grappling with their loved one's prognosis and future recovery and finding that new normal for both the patient and for themselves. So scientifically, the way uncertainty behaves, it's not just a lack of knowledge. It's that feeling of not knowing. So it can show up as information gaps, it can show as unclear situations or the emotional strain that comes with them. And there are neural mechanisms. The brain has these areas, for example, amygdala or other parts of the brain like prefrontal cortex, where it guides our responses to the future threats of uncertainty. So certain people may be a little bit more comfortable with uncertain situations, while others really need the answers today. And despite the family members' clear desire for information and high levels of uncertainty that I just discussed, the information-based interventions that have shown to limit uncertainty and improve the psychological burden of this event, um, some effectiveness seen in cancer, have never been tested after cardiac arrest, or that too in a very acute care setting, which means right after this event happens and not 6 months later. So we were very interested in understanding, before Heartsite came, like what are we trying to build? What is the need of the family member after their loved ones experience cardiac arrest? So this is a summary of experiences of around 3,600 close family members of cardiac arrest patients. We've assembled 44 studies and summarized it done across 15 countries, 5 continents, and really it highlights the persistent levels of anxiety and post-traumatic stress, leading to a very high caregiver burden and reduced quality of life. And not surprisingly, in some studies, it shows that the psychological distress is equal, if not greater, than the survivor themselves. And the recommendations made by the family members were frequent communication and with the fam with the medical care teams, providing information on recovery of their loved ones, and then also knowledge about the disease conditions. But on top of it, more about, if I have more questions, is there a way for me to connect with the team again? After that, once we saw that what has been published in the last 50 years, we conducted a prioritization exercise led by Jennifer Chapp, a co-survivor herself, and we did a national survey with 550 close family members who were within the first 6 months of the cardiac arrest of the loved one. And here you can see that when we give them 8 unique choices of where should we put our resources, what should we develop as a team of people who are interested in creating resources for family members after the cardiac arrest of their loved one, they prioritize education and information-based needs. So the top rank was education on potential recovery of the loved one. How do we know? What kind of knowledge should they have? How is this condition different from stroke or heart disease, heart attacks? And again, access to care team even beyond discharge and then rehabilitation options. And the focus on well-being of their own well-being needs was there, but not as strong in the first few months compared to the education and information-based needs. And this was more evident when we did the journey mapping based on their responses. And you realize that the people's needs are not static. They shift over time. For example, in the early phases, their highest priority is getting the clear, accessible education, but as the time goes on, their needs evolve, and that's why I think beyond few months, maybe the research or the intervention should focus on easing the burden the family members and the caregivers carry. So this was a survey design, and we really wanted to see if this is something we should be learning as the family members go through their experiences from the moment it happened. So to do that, we conducted a prospective study among a racially and ethnically diverse group of family members, uh, where the patients were admitted at Columbia Medical Center, and really within 24 to 48 hours of the event, we would go to the family members, develop a rapport, and then ask if they would like to participate in a study. And initially, my my suspicion was that we're going to have almost nobody participating because it's such a vulnerable, difficult time for the families. But again, one more time I was wrong, and they were actually very welcoming. They were saying that we were the first ones to ask how they are, rather than everybody in the hospital just coming straight to the patient and then just doing interventions and leaving without acknowledging the families present at the bedside. So very few declines, and we really was able to get 100 family members enrolled into this prospective study design, where they will first come in, we will have a questionnaire, we will talk to them, and then once their loved one moves to the floor, we will have more interviews about their experiences. And then a month after the patient's discharge, we would call them again and assess some of the psychological distress markers and other things that we were interested in, including sleep. So here we really saw that the family members express a lot of distress. It sort of like shows up in screening questionnaires as depression. Like a lot of them had major depression already within the first month. Generalized anxiety, just anxious about things, how it's gonna all play out, all sort of like markers and indicators of uncertain situations and uncertainty. And some of them were already moving towards the post-traumatic stress disorder. And when we really wanted to know how is it impacting the patient, the survivor, because all of them are now going home together. So the survivor will have their own set of anxieties and post-traumatic stress, and then the family member is carrying their own burden. So we saw that out of the three things that a patient could have, as we know from the post-intensive care syndrome model, that they could have cognitive impairment, they could have physical dependency, and they could have post-traumatic stress. And this is from a parallel study that we were doing with the survivors. So we had that data along with their family members' data, and we could see that the family members' distress was very closely connected with if the patients are also exhibiting stress. But we couldn't tell which one came first. Maybe it's the other way, that the family members are more stressed out and then that is transmitted to the patient or their loved one. So it's that sort of like dyadic interactions between these two needs to be figured out. But we do see that they're all in this together. It's not that one of them is totally fine and the other one is very affected. And then the other thing that it says is that if you want this family to recover, to find a new normal, to move forward, you have to work on them as a unit, as a dyad, rather than individually. You provide resources to one but leave the other one behind. And again, administering the same questionnaire about what do we do for you, the prospective sample confirmed our findings from the survey that education, education, education among the top, actually here, among the top four options that they picked as first ranks and second ranks and third ranks combined. So it really reinforced that the information is where we need to go and sort of develop a platform for them. So in a summary, what we have learned is that families suffer significant psychological distress after their loved one's cardiac arrest. It's associated with poor sleep health. The data didn't show, but the family members' sleep habits significantly deteriorated compared to how they were before the cardiac arrest, and this is measured at 1 month after the event, after the discharge, actually, not even the cardiac arrest event. And then again, three-quarters of the families want informational resources, and they believe that this will help them have less psychological distress. But that's when the rubber hits the road. We found that families, during this process of interviewing these families at the bedside, they were mostly left to their own devices to Google their way back to emotional well-being, and there hasn't been one place where they could go for comprehensive guidance. It's very fragmented, and really working with different people. For example, Jasmine Wiley, who runs the largest peer-to-peer support group in the country, really said in a very eloquent manner that her group, her Facebook page is trying to fill this gap of information, but really the evidence or the information needs to be trusted. It needs to be backed by the evidence, and then sort of like blended with the experience of others. So that's where I think we got the most guidance of where do we go from here. And really, as a clinician, as a researcher, uh, who has done a lot of the publications and manuscript writing, I really believe that we don't write for who the science really belongs to. So we have this bridge between the scientific evidence, the guidelines, the statements we write, and the community stakeholders. This bridge is sort of broken, and then this breach is in communication leads to this significant gaps and information gaps, especially if there's poor health literacy, and then there's also misinformation among people who are affected because they get information that may not be as beneficial or could be harmful at some point. So a group got together, and we aimed to sort of decode the scientific evidence into very lay-friendly language, and then blend, sort of like mix this information, design this information with lived experiences of people who have gone through this traumatic event. And the other portion was to making these resources really accessible to the diverse communities impacted by cardiac arrest. And that's where the Heartsite was created. The Heartsite content sort of highlights and addresses the key moments where people affected are really uncertain. And it currently has more than 100 articles, again, written by the clinicians, researchers, and then sort of like blended, and the people with lived experiences worked on them and put their own perspective. And that's how each article is. It's very lay friendly. It's eighth grade English level. It's bite size, so it's like less than 1,000 words of each article. Multiple languages it has been translated into, and we had a whole process of how to make it evidence based. So there was a development process. We followed the guidelines, and then of creating an intervention, and then got it peer reviewed by three established researchers in this space. And the way it's structured, if you go to the resource, it talks about the hindsight, which is what happened to my loved one, and what happens now. It introduces them to the ICU, the hospital setting. Where do you sleep tonight? Where do you eat? What kind of resources are available? What are your doctors saying? And then it goes into the articles that discusses about the discharge planning and what you should know, and what is a life vest, and what is an AICD, what kind of medications, what kind of cardioprotective behavior you should get information on. Um, and then finally, the foresight, which is it's about you, the family member. And I'm just talking about the family members, but most of the other stakeholders that we discussed, they are there, and they all go through the same levels of hindsight, insight, and foresight. And how do they all heal, and how do they all recover from this event? So Heartsite was introduced at the World Expo, and then finally sort of launched at the Cardiac Arrest Survival Summit. And a lot of us who were part of this initiative came together for the first time in person because all of this work it went on for a year, but all of this work was done remotely and through Zoom calls, and the engagement in getting this initiative out was tremendous, and that's why we were able to do so many different stakeholders work simultaneously and not sequentially. And currently, it's being consumed globally. We launched in 2023, late 2023, and currently it's 156,000 visits have been done by different countries, people from different countries. It's being translated and being asked to be part of their health system across several countries. And it's still not covering the gaps. I think it's just the beginning, and we believe that with the help of all of you, we could even make it further into the hands of people who deserve it, who needs it the most. One thing when we first started was what is our vision statement? What are we here to do? And what are we really good at? And what we're gonna be able to accomplish? And the two words that are really, we had consensus on is to be the first, which means it should not wait until the months pass by and then the family members have already gone through, or the other stakeholders have already gone through the process and then sort of stumbling upon it. And the other thing is the trust portion of it, that if they see some information, they should be able to say, yeah, that's what I think what the doctors would say, the research has found, and this is what I would like to adopt to my lifestyle. So to do that, I think let's talk about to be the first. We believe that there are three different phases when something like this could be utilized. There is initial moment when the home, which is 80% of the out of hospital cardiac arrest or public locations, where you could have the families of patients who are going to be hospitalized because you have return of spontaneous circulation, or the families of patients who did not make it and they have to be pronounced by EMS right away at home. And then there are first responders who came and sort of like called for this 911 call, and then the late responders who provided CPR. And you will lose some of them if you think that this kind of resource should be offered in a hospital setting. So here we are trying to understand like what should be the prioritization for dissemination. Where should it go first? Where should we go to make sure that at least that portion is covered? And then it comes to the community where people have to just find you. Um, and we all believe that the primary distribution point should be the first, because bereaved families, lay responders, and sometimes the first responders, I think, really deserve to have this information because they all go through their own set of traumas, and it needs to be resolved. So we think that this is the touch point where we want to deliver it. So how do we go about doing that? We believe that having a card, having some kind of a QR code with resources, and maybe, it has in the back of this card is something about the fire academy or the EMS agency, so that they can personalize it. And then the idea is that once the EMS has sort of done their call, they give this card to the families and then the lay responders and then the people around them to sort of like bring a closure to this engagement where like their time with this family is over, but here are people who are very dedicated to be helping you, and whenever you feel that you're ready, you should connect with these resources and they can help you. So that's the whole idea. And we have started testing it at few places in the country, both in United States and Canada, because Heartsite is a North American initiative. So there's a lot of people joining from Canada, and then we have others from the United States. So this is an example from the Peel region from Canada, where they have developed the front end is their information and their paramedic services, and in the back is the information on Heartsite. So, and what we are able to do through our website, able to track who comes from this Peel region and how many people are actually going to the website once they receive this card or this baggage tag in this case from them. So currently we are trying to recruit different EMS agencies and trying to see who will be interested in piloting this idea, because you also want to know whether this could be feasible in terms of going forward, what the ROI for the EMS teams, and how many people actually consume these resources. Another way we are sort of distributing this is through Pulse Point. So we tied up with Pulse Point, and as the Pulse Point send their lay responders, information about, hey, here's a cardiac arrest close to you. After they have responded, they receive Heartsite resources as a default. So that has definitely, so again, we can track how many people are actually getting it from Pulse Point who are using these resources. So something of this sort is very interesting, and very sort of like in the future could be the standard of care. The second portion was about the vision statement was trusted. So how do we know that the information we all created really helps the family reaching to a point where they feel, yep, I am definitely better than what I would have been without this resource. So again, coming back to the research idea, the gold standard of randomized controlled trials. So again, coming to the Columbia Center, same process that we had. Within 24, 48 hours, we were able to randomize this time family members into receiving Heartsite informational resource versus whatever the hospital is able to provide, which I know my hospital is not much. So for the Heartsite group, they will get the hindsight resources in the beginning to understand about the ICU, about the hospital, about the prognostication, about what doctors are saying. And then at the time of discharge, they're going to get another package, which is the insight. And then at 1 month, they're going to get the foresight informational package. And then at 3 months, we would call them and get a qualitative interview, but also understand what kind of a change in the distress that we have sort of like done through this intervention. So 15 articles in the beginning, then 7 articles for during discharge, and then the 12 articles for focusing on you. And so we got 32 people enrolled, 2:1, so around 20 people with Heartsite, and then the control arm was care as usual. So here's what we found. The idea was to see if this is even feasible to do it in a hospital setting. So we were able to meet all feasibility aims, whether it's recruitment, retention at 3 months. Are they going to use this resource or not? So utilization, and also if they completed all the questionnaires. But also they found it very acceptable to have something like this within 2 days of their loved ones coming into the hospital, and also appropriate. It's not that it's a nuisance for them. Definitely the usability potential was very high. Now, this is very exploratory because it's a small sample, but when we check the uncertainty levels, you could see that the Heartsite arm and then the usual arm were slightly similar in the beginning when they first came in. At the time of discharge, they pretty much like came very close, which means even the usual care, the conversation doctors were having, or whatever information they could gather from Google or others, it's not as different. There's a separation, but it's not as different. But as soon as they go home, I think the two paths become different again. So Heartsite arm, the uncertainty continues to go down while the usual care goes up, which means the need for this kind of a resource is a lot more like at the time of discharge and beyond. And this needs to be tested again in a future study with the larger sample size. This is just a trend. Similar sort of like symptoms, like PTSD symptoms, but you can see they are sort of different from the beginning. This is just the nature of the sample. But the Heartsite arm continued to have lower post-traumatic stress, while you can see with the usual care, things go up again as they leave the hospital setting. The main thing we were aiming for is the caregiving burden, which means that after all said and done, how do you feel about taking care of your loved one when you go home? And that's the major or the main primary aim that we had when it comes to exploration and exploratory stuff. So here we saw a significant difference that the Heartsite people who were randomized to Heartsite arm had lower average caregiving burden score compared to the usual care. And I think this just says that things beyond hospital discharge, really when they go home, things become very different and very sort of uncontrolled and uncertain compared to when they're in a hospital setting and they can talk to the doctors and talk to the teams and get a lot of information. There's a lot of social support, a lot of family members come together. And once that discharge happens, everyone goes and say everything is great, someone has survived, pat on the back, you are a miracle. And then the families are just left alone with their own set of informational gaps. So the take-home message of this work was Heartsite-like programs, I think, are feasible, acceptable, people would love it, use it, but also has a potential to reduce some of this trauma, this uncertainty that we have been discussing today, um, and could potentially reduce their caregiving burden, which they are very sort of like they feel very honored to do it, but it still takes a toll on their own lives and mental health. Some of the qualitative feedback we had was focus on early intervention benefits. They felt it was very timely, earlier the better. So I think giving this information in a hospital setting makes total sense. Also, they felt like it was integrated into learning from the other things that we're getting from the hospital setting. And some of them, or most of them, don't have medical background. One thing we were concerned about is the technology. So this is not a pamphlet. This is not a brochure. This is not someone coming to you and saying, "How are you doing? What can I help you with?" This is a this is a web page. This is a website. So how is the technology translating into real help? Um, the comments we got were very good. That accessing this information and working through the website because it's created with a very user-centered design method. So it was very simple for them to find this information. Even older folks were able to get on the website, or non-tech savvy said, "We figured it out." People forwarded this information, the participants, to their older family members, including people at home, to say, "Hey, I'm liking this information. You should read it too if you want to make sense." And so those things were great, but one of the feedback that came is reading, the read-only format. So this is a format where you have to like read. You're in a waiting room. You have a phone at best, and you're trying to read these articles, even though they are short, even though they are simple, even though they are in a language that you can understand. Still, reading requires focus. And that's what we got from them is that, wish there were other ways to consume this information. And also, if the focus is not there, attention is not there, it may not be sticking as much. And so we started looking into podcasts. How do we create this information? Maybe an audible format where someone just reads the article. And I think I found personally those things a little bit more, you doze off and you become sleepy. Uh, but the AI has been working in this regard in terms of like Google Notebook, large language models, where it's not a human, but it's a human voice, a human-like voice, and they can actually convert these content into something that's more like a conversation between two people. And the idea is, could family members like putting like a headphone and just listen to this information in a format that it's more interesting, a little bit more that stays or sticks with them. So we said, okay, so how about we worked with Google, a team in New York, and created these podcasts of 5 articles, and then another 5 articles of just read-only format, and then randomizing them again, this time not from the hospital setting, but people who are family members of cardiac arrest survivors, giving them this option of read-only format versus the podcast. And then the goal is to see pre and post test how much information is sticking and would they like this format over read-only. And again, here there are some scientific sort of like a neural mechanisms that the areas of the brain that are involved in listening are much more sort of compatible and much more integrated with the memory areas of the brain. So could it be that if the mode of engagement is listening, they may actually retain this information more. So that's the mechanism why we believe that the listening and the hearing of this information will probably have a better chance than just read-only format. So just to give you a sense of like how it's used
Welcome
by.
to Heartsite, Understanding Cardiac Arrest. We are here to provide education surrounding all aspects of cardiac arrest and cardiac arrest recovery for all of those impacted, surviving cardiac arrest.
Well, it's a journey that really extends far beyond the hospital doors, doesn't it?
It absolutely does.
Coming home is such a huge step, but it can also bring unexpected challenges, uncertainty for you and your loved ones.
Definitely. It's a time when, new physical feelings or emotions, maybe different ways of thinking might pop up, and just understanding that many of these things are, well, they're quite common. It can offer some comfort, maybe help you feel a bit more prepared.
And that's exactly our focus for this deep dive. Based on the information out there, we want to look closely at what many survivors and their families too can perhaps anticipate during this recovery period back home.
So yeah, so I mean, this is like an older version. Since then, we have worked a lot on the tone and the compassion, and then the idea is how much can we bring it closer to how we want this kind of information to be delivered to someone who's going through tough times, who is very vulnerable, and but again, the convenience of creating information, the content that you have into something more digestible, more in a format that the family members may perceive to be a little bit more friendly. We'll have to see through this study, and then we already have 35 family members enrolled, and we are looking for more. So if you guys can disseminate this idea, and I have my email address at the end, please reach out. And if you have any family members who would love to participate, also we are taking multiple family members if they're interested from the same family. So something we really believe will change the way how we think of Heartsite in the future. Maybe the content, the information is delivered in multiple different ways. Another layer of AI technology, that's developing is the video assistants. For example, when you come to this website, it's you have to search, you have to come up with your own, who you are. You have to like pick you're a survivor, you're a co-survivor, you are a late responder, and then you get all the content for you. So it is at least one click, but it could be that in the future you come to the website and someone is speaking to you and asking you how they can help you, and based on what you say, they can sort of like search all these 100 articles content that we have and then give you the precise information that you're looking for on that particular moment, because you may be there just to see what should I say to the doctors if they ask me about AICD, let's say. You have to look for all the articles that we have. We have a search thing and it works beautifully that you can search for certain things, but I think this will become a little bit more sort of like personalized. So, and then as the technology improves, even the pictures, the person could be just one of us. The other thing I discussed is about the dissemination strategy. So few of us are very passionate about it. Katie Dainty from Toronto and I and others have started sort of like talking to the sites across the country into would they be interested in creating some sort of like a consortium where we can pilot this idea of giving cards or something, a QR code to the family members through the EMS agencies and trying to see the implementation of this idea and how this could be fruitful for all of us if it's a win-win situation for both sides. The last thing is I only discussed the family members module, but there are modules for survivor, there are modules for parents, and since we've started working with the children's hospitals from both United States and Canada, we are also working on creating similar to resurface study that I showed you for kids. So that's also upcoming in the next year, 2026. And really, I think there's just no limit to where this all it could go, as long as we all together in this and sort of like working towards finding new ideas and just dream big. So I'm going to end here. This is the QR code for the website. Please feel free to go, or if you have time, we can all go and explore the website together. Please note down my email address if you have family members or of cardiac arrest survivors who are interested in participation in our audio listening study. It's a very quick study, but it will give us the insane amount of information that we're looking for to make this better. So thank you again for listening, and I'm open to any questions, and I'm sure a lot of Heartsiders are on the webinar, so they can help me answer some of them as well. Thank you again.
That was fantastic, Sachin. Thank you so much. And, there's already several folks in the chat who are itching to reach out and probably are flooding your email box right now. So, as they say, RIP to your inbox, right? I think it'll be flooded. And I'm going to send one myself because this is just absolutely tremendous. And my agency here in the Seattle area would love to be involved and see how we can join the partner to improve this. I think really, I think there'll be an effect on the responders too, right? It's often our crews leave the scene and feel like they want to do more for that wife or that family member and don't know what else they can do for them other than what they've done for the last half hour.
Yeah.
And so having a resource like this that they can point folks to that has evidence behind it, holy cow. I mean, that is just fantastic and really, really good work. A bunch of questions in the chat. I'm going to start going through some of them. One of the agencies, or one of the comments in the chat was talking a bit about how you've sort of covered some of the data with family members, and I think one of the questions is how do the folks who are sort of lay responders, who are a stranger to the patient, is there any data out there? Have you guys looked at those folks in any organized way to sort of see what their experience is? And there's an anecdote shared in there that discusses a family member who was a lay responder who really, it was a major event in their life as a person, as a human, and had some effects from that. And so I think it's an interesting population for sure. Curious what you guys are thinking about.
Great question. And Andy, I think since I work mostly in the hospital setting, so my experience is mostly with working with patients and families and involved parties like from the hospital setting. But I know Katie Dainty has worked a significant amount of work in the lay responders, and a lot of statements like 2022, she had written a statement with American Heart Association, and that talks a lot about the experiences of lay responders. And I also know that Paul Snoblen, who's a paramedic at Peel Region, Canada, has actual data. I think this is the question. Actual data to understand the experiences of lay responders, and I know he's in the process of summarizing everything and getting it out there so that people can benefit. Mostly just normalizing and understanding that it's not easy, to be a lay responder, even as a first responder, even as a professional first responder. The other thing we're learning from is Pulse Point, right? So Pulse Point saw this need, right? Because they were able to do survey their lay responders who they were sending, and then they understood how some portion of the lay responders were having trouble with this experience, and it's a trauma.
Yeah.
So they need trauma-informed care, and that's
Yeah.
where we worked with Richard and then created a resource for pulse point responders.
I
Also,
love
I see
that. And
Katie in the panel. If Katie wants to
yeah,
speak more about it.
I tried to promote her. Perfect. You were name dropping, so I figured we'd get Katie right on when I saw her in the audience.
Oh,
Thanks for joining us.
Katie is a big part of Heartsite. This could have been just given by Katie today, the presentation.
No, not at all. Fantastic job, Sachin. So great to see everyone. Yeah, I put it in the Q&A. I'm not exactly sure how this works, but we just actually published a paper earlier this year about the unique trauma that family members who are lay responders experience and how we have to think about that a bit differently in the resources that we can provide. So I put the link in there.
We'll send it as part of our
open
follow-up.
access.
We'll send it as
Yeah.
part of our follow-up email too. So that's
Great.
awesome.
Yeah.
Thank you.
And it definitely is something, I have said for a long time that I think, we've asked for years, we've asked people to, save someone's life, but we haven't really spent much time thinking about the impact on them, lay responders, family members, and even healthcare professionals for that matter, who are, acting in a lay responder capacity. It's not the same as when you're, in the OR or in the emergency department, when you're helping someone on the street. So these are all the future, I think, of understanding how we can improve how we support lay responders and even how we talk about by-center CPR in general. So
This is just tremendous, you guys. I can't say enough good things about the work that you're doing. I can't wait to tuck these business cards in our AEDs and have our folks hand them out to somebody who's doing CPR on the scene.
Nice.
Or somebody who's standing there who, might just need a little support down the road, family members, sort of all the appropriate things. This is just super exciting and really tremendous work. What do you see? Where do you see this heading next, Sachin? And Katie, feel free to jump in. I'm kind of curious, 3 years from now, 5 years from now, where do you guys see this program heading, and how can we all, as a resuscitation community, help you get there?
Yeah, I would say I think the one thing is just like how we looked at the family members module, whether it's really effective or reduces some of the uncertainty. I think every module that we have needs to be tested independently for its efficacy, because we cannot say that we are researchers or we believe in evidence until we test our own work and see if it's evidence-based or not, right?
Yep.
Updating the information is one portion of it. So I believe that slowly and steadily, people will take it as, this work, obviously done by all of us volunteers, but then the research components have helped PhDs getting their dissertations done. People have come and wrote articles for us. For example, the PEDS module, they're like a bunch of kids who are writing, people who are survivors, and they had it when they were like young. They wrote the article. So I think it's just a very community-based collaborative effort. So I think that's one portion I would like to see in a few years, that everything is sort of evidence-based and tested and has its own level of efficacy. And then the second portion is the effectiveness that we discussed, that this was created for people who are very early on, like in the waiting rooms, when it happens. And I think we cannot make this successful, or we cannot call this initiative successful until it's in the hands of the people who are just experiencing it now. So, and that's where we need the most help. Katie and I are very dedicated to creating some sort of like a group of people who want to test this across North America. And I think that will take a few years. And then I think one of those two things are my top priorities, along with some of the AI, utilizing AI and then making it more streamlined. And the reason why I'm thinking about AI and not human factors is because the cost. If I tell you how much money it took to create this website or create this resource that we are all discussing here, it's $0.
Yeah.
It's all hard work.
Yep.
None of us had to put any money in. Everything, including the website, was created by our own team member. The user-centered designing was done by someone who has expertise in this work. So everyone contributed. The cost has been $0, and I would love to keep the cost at $0. Then it's sustainable. Otherwise, a lot of these initiatives, don't end well because there's no money left. And I don't want this to be funding-based initiative.
Mhm.
Go ahead, Katie.
Well,
Yeah, I agree. I think it was Margaret Mead that said that never underestimate what a very thoughtful, committed small group of people can do, right? That's pretty much the motto of this group. But I do think that the reason, a lot of people say, oh, it's just a website. It's just, it's just information. But this is just one, I think, component of a toolbox that we'd love to build. It's kind of the anchor, but we kind of took the perspective that we could talk about doing all kinds of fancy things and never get there. We just got to start. And so we started, and it's a great start. And I think it's very useful for many, many people, but there will be other people who need other pieces, and that'll be the AI pieces that Sachin's talking about, or building some video components to the website, or other ways of accessing the information, or creating dissemination avenues like we were talking about, the cards and the AEDs, or an app. We're currently working on some work for survivors and family members through an app where Heartsite is the information resource. So I think it's just one tool in a toolbox that we would like to build that gets information to people when they need it. That's sort of the bottom line, is just getting information to people when they need it.
yeah.
And
One more
even when they don't know they need it.
Yeah.
One more question in the chat, and I'll frame it a little bit for you. It's a paramedic and flight nurse friend of mine from Alaska who is asking any specific resources or specific work you've done around two populations. One is rural, right, which I think is can be a very isolating population when their loved one suffers a cardiac arrest and they're not nearby the center of excellence for care at an ICU level and those sorts of things. And then also the opiate use population, right, where we're seeing a ton of arrests in opiate patients and a ton of morbidity and mortality that's related to that clinically. And so I'm kind of curious if you guys have dove into those two populations or others specifically, and any specific sort of thoughts or interventions or learnings that might be helpful.
Yeah, I mean, I can answer to the first portion because it's easy. Yes, a lot of the information that we have on the website, there's no sign up, you don't have to pay or anything. So it's very open. And then you could be any of the stakeholders and be able to get benefit from this resource. We wrote a lot about the simple things and not something that requires, a big hospital setting. The language is not a barrier with this website, so rural areas could do that. The other thing that we're working on that's going to be on the website very soon is for the primary care docs. So this will be not like a full hindsight, insight, foresight sections, but like a two-pager, a PDF kind of thing, which will have if someone approaches you and is either a survivor of a cardiac arrest, or your patient is actually a family member of a cardiac arrest survivor, or bereaved family member, or a lay responder, what's your role? How do you understand? Because you don't see these kind of patients in your setting, in your clinic setting every day.
Yeah.
So first you need to be educated as a primary care
Yeah.
doc. So we are creating this two-pager which will go into, hey, this is what you need to know, ask these questions. This is the issues that may be coming with, here are the resources that you can give to this person. Because I think at some point, everybody who's gone through this needs to be acknowledged and valued. And I think if they see that their primary care doc understands what they're saying, I think it's going to go a long way. So I think once that two-pager comes in, it will solve a lot of the issues that happens in rural areas, because that's where, it's very difficult to find doctors who understand what cardiac arrest is.
Absolutely. That's
But
fantastic.
nothing we have done so far that's really geared towards opioid overdose. We
Yeah.
have most of the cardiac arrest these days I see are opioid overdose related, but we don't have any articles that are written in that population, and they are mostly younger people. And I think this is a great idea for us to write more about it.
Yeah, I think that's a great opportunity that's sort of sitting out there. But yeah, fantastic. Awesome. This is wonderful. Lots of positive feedback in the chat for you too. So thank you both for joining us. Katie, thank you for your last second join. Here's my flag I'm going to put in the ground, right? Based on the data I saw today, I think 5 years from now, you guys are going to have a study that shows that the patient does better with this intervention. because the family can support them and they can get what they need. And that is, I mean, from, as simple of an intervention as this is, I think it's going to show tremendous efficacy. And I'm just super excited to follow along and hopefully be a little part of it with our agency. So, like I said, RIP to your inbox, Sachin. We're going to fill it up today, tomorrow, and the day after. We'll
I'm
send out
glad that you
some
gave them
resources
your
for folks.
email, Sachin, not mine.
We're going to get
I'll
you
take
some,
one for the team, Katie.
we're going to get you some agencies, and we're going to get you some enrollees in the study, and things are we're happy to partner, and however we can help from the RA perspective. Love what you're doing, love the way that you're doing it, and really tremendous. Thank you so much for joining us.
No,
Thank
thank
you.
you. A big thank you to all the Heartsite members. They did all the work. We are
That's
just
right,
here
they
to
did.
represent them and speak
It's a
to them on their
tremendous
behalf.
team you've put together, so really, really awesome. So
Thank you.
we're going to wrap
Thank
it
you,
up
Andy.
there. We'll be back October 16th for our next webinar. Excited to announce that the guest will be Carl Kern. Many of you know Carl. He's a cardiologist from Arizona, from Tucson, Arizona. And he'll be talking to us a little bit about sort of, I believe the topic is the cardiac arrest care pathway that has come out of Arizona, and kind of the how and the why behind that, which is really a tremendous topic. And Carl is the guy to talk about it, and he's a fantastic speaker. We've been working on this one for quite a while, so I'm excited for that one as well. Sachin, again, thank you. Katie, thanks for the last minute promotion to panelist. We appreciate having you. And we will see you all soon. And I'll be emailing you, Sachin, and others will too. So thank you so much.